Thrombocytopenia. Among thrombocytopenia, we will discuss two major components, that is thrombocytopenia due to immune-mediated destruction, which is ITP, and drug-induced thrombocytopenia, because these are the two major entities we come across in our clinical practice. Then in the end, we will discuss briefly the inherited platelet function disorders. So both quantitative and qualitative defects will be discussed. Okay, so this is just a revision of your of what you have learned in your foundation year. We know that hemostasis basically is a mechanism through which the body tends to keep blood in a fluid state within an intact blood vessel, and whenever there is an injury to the blood vessel, it is prevented from excessive loss due to activation of different partners of hemostasis. These include the vascular response, the platelets, and the clotting factors. The major vascular response is by vasoconstriction. In this way, the loss of blood is minimized, followed by platelet activation, which gives rise to a temporary or the initial hemostasis called primary hemostasis. Platelet, they bring about the formation of a platelet plug through different steps, which include platelet adhesion, activation, release phenomena, and platelet aggregation. This is followed by stabilization of the clot, and this is brought about by the activation of the coagulation pathway, namely the intrinsic pathway and the extrinsic pathway, the end result of which is fibrin generation and formation of a stable clot. Following this hemostasis or formation of a clot, ultimately this clot undergoes resorption, which is brought about at the same time by activation of fibrinolysis, and hence healing takes place and any remnants of the plug or the fibrin is removed. So these are the normal mechanisms which take place in a person following injury or trauma. There are these changes take place inside the body, or these are the in vivo actions. In vitro or outside the body, we can assess their function through different tests. For vasoconstriction or for vascular integrity, a rough idea can be obtained through bleeding time, which tells you the time which a blood takes to clot. This is followed by platelets. We can conduct platelet count to determine whether there is thrombocytopenia, to look at the morphology, and if the counts are normal, then their qualitative function is assessed through bleeding time and more accurately through platelet function tests. For coagulation pathways, we conduct prothrombin time to assess extrinsic pathway and APTT to assess the extrinsic one. Sorry, the PT to assess the extrinsic pathway and APTT to assess the intrinsic pathway. See, this is a diagram to go through what I've just informed you. Through vasoconstriction, blood flow is reduced, then platelet aggregation takes place, and at the same time, they also provide a surface for the clotting factors to form a fibrin clot. And once this secondary hemostatic plug is formed, it undergoes lysis, releasing fibrin degradation products. Now, broadly, bleeding disorders can be divided into four major groups. The vascular disorders, which we will discuss first, then platelet disorders, which include both quantitative defects, that is thrombocytopenia, and qualitative defects. And then we have got coagulation factor defects, which could be either congenital or acquired. Fibrinolytic defects are also included, and we'll touch upon them briefly, especially DIC. All right. Now, there are certain vascular response disorders which give rise to excessive bleed. Most commonly, vascular disorders cause minimal bleed. It is mostly confined to the skin in the form of petechiae or maybe purpura. Sometimes GI bleed can also take place. The most common cause of vascular bleeding are the infections, especially meningococcal infections or severe sepsis. The mechanism is the direct damage to the vasculature, giving rise to its inflammation, and the patient could end up with DIC, which is a very serious form of the disease. Initially, especially in meningococcus, the patient presents with petechial rashes, and once the disease is aggravated and is not controlled, ultimately there is massive widespread hemorrhage. Then there are certain drugs which cause drug-induced immune complexes deposition in the vessel wall, and it gives rise to cutaneous petechiae and purpura. Then vitamin C deficiency in scurvy, Ehlers-Danlos syndrome, which is an inherited collagen defect, and Cushing's syndrome, which is because of increased steroid intake, either iatrogenic or because of excess production within the body. They all give rise to collagen defects. And due to collagen deficiency, the integrity or elasticity of the vessel wall is lost, so it cannot undergo vasoconstriction. And they are also manifested as skin hemorrhages. Then we have got an autoimmune disorder, which is Henoch-Schönlein purpura. This is a special disease in which there is deposition of immune complexes within the vessel and the kidneys. They are characterized by palpable purpuric rashes present on the legs and the buttocks. These patients usually present with acute abdominal pain as well. Then there is another disorder, which is hereditary hemorrhagic telangiectasia. It is characterized by the presence of dilated and thin blood vessel present on the mucosa, especially on the face and within the oral mucosa, which have a tendency to bleed readily. They are present around the nose, tongue, mouth, eyes, and if they are present within the GIT, then it may result in a heavy bleed. This is the only disorder in which heavy bleeding is expected. Otherwise, the rest of the vascular disorders, if they are treated appropriately, they give rise to minor bleeds. Then we have got perivascular amyloidosis. Amyloid protein is an abnormal protein which get deposited around the blood vessel, making them thin. And it can also give rise to mucocutaneous rashes. Now coming to the platelet disorders. As I mentioned before, either the count is low, which is thrombocytopenia, or the count is normal or low normal, but they are dysfunctional. So what are the major causes of thrombocytopenia? We use the term thrombocytopenia when the platelet count is less than 100 into 10 to the power 9 per liter, the normal range being 150 to 400. Low platelets can be because of production defect, or if the production is fine, they may be because there is increased destruction in the circulation. Or another reason is there is splenic sequestration. Whenever spleen is enlarged, platelets, they tend to pool in the spleen and may cause deficiency. Then there is another condition in which there is dilutional thrombocytopenia, that is following excessive blood loss and massive blood transfusion can give rise to dilutional thrombocytopenia. Okay. So decreased production can be because of decreased thrombopoietin, which is a growth factor which acts on the bone marrow on the megakaryocytes. Or it could be due to viral infection, marrow damage, or replacement, certain drugs, congenital defects, and ineffective production, especially B12 deficiency. Increased destruction can be divided into non-immune or mechanical trauma to the platelets and immune causes. Excuse me. Most important of which is ITP, or immune-mediated thrombocytopenic-IT, followed by drug-induced immune-mediated platelet destruction, which includes heparin-induced thrombocytopenia. Okay, so what is the etiopathogenesis in ITP? Basically, the main cause is the formation of autoantibody. That is, an antibody is produced against our own platelets due to immunomodulation. That is, the immune system of a person's body undergoes changes and it fails to recognize its own platelets, but considers it as a foreign object. So there is B cell activation, formation of antibodies which are directed against the glycoprotein 2B3A, which are the receptor present on the platelets. And these antibody, they coat this receptor through the process of opsonization. This complex is then taken up by the FC receptor of the macrophages present in the reticular endothelial system, mainly in the spleen, and they are destroyed or removed from the circulation. Some of these antibodies are also directed against megakaryocytes in the bone marrow, where they combine through receptor glycoprotein 1B59 and they cause reduced production of the megakaryocytes, okay? Or their maturation is defective. So this is how ITP occurs. We classify ITP based on the underlying cause into primary ITP and secondary ITP. Primary ITP is when there is no underlying cause detected. It is also called idiopathic ITP. The secondary ITP is due to secondary infection like hepatitis C, B, or H. pylori, autoimmune disorders like SLE, and lymphoproliferative disorders, which include lymphomas. Then we have got another classification which is based on the onset of the disease. This includes acute ITP, that is when the disease has a rapid onset, patient gives a very short history and it tends to resolve on its own within 6 months. Then we have got chronic ITP. It has a gradual onset, may persist for more than a year, and it has a typical waxing and waning pattern. That is, it goes into remission and then it exacerbates on and off. The type of bleeding which we encounter in ITP is mucocutaneous, that is mostly in the skin or in the mucosa. So the patient presents with either epistaxis, gum bleed, menorrhagia, and sometimes melena. Morphologically, if we look at the spleen, there is congestive splenic sinusoids with scattered megakaryocytes. The diagnosis is basically based on exclusion. That is, first we determine the presence of thrombocytopenia on CBC. Platelets are usually large in size, which indicates that the marrow is trying its best and is producing immature platelets, just like immature red cells, which are larger than a mature red cell. Large platelets are the immature platelets. These are also called megathrombocytes. Bone marrow biopsy is mostly normal. Megakaryocytes are present. In fact, they are increased with many immature basophilic forms. We can differentiate between the two types, that is acute and chronic ITP, based on the age. Chronic ITP is seen mostly among adults and females, whereas acute ITP is present in children. The onset is gradual in chronic, whereas it is sudden or acute with a very short history in acute ITP. Diagnosis is based on exclusion, that is, we have to rule out the secondary causes of ITP, which I've mentioned earlier. And then it is in acute ITP, most of the time there is a prior history of a viral fever. Mostly we see children post-vaccination presenting with ITP, or post-measles ITP is very common also. Relapses are common in ITP, whereas acute ITP is usually self-limiting and tends to resolve within 6 months. Treatment, since it is an immune-mediated disorder, we use immunosuppressive therapy, steroids, immunoglobulins, splenectomy in some cases. In children, usually we use wait and watch policy and only give steroids if thrombocytopenia is severe. There are certain newer drugs in the market which include thrombopoietin analogs and anti-CD20, which are more commonly used as an upfront treatment or those patients who are refractory to steroids instead of splenectomy. Among the children, about 80%, they ultimately the disease resolves, but in 20% can develop chronic ITP. Now we come to the drug-induced thrombocytopenia. The drug-induced thrombocytopenia is broadly divided into two major groups. One are the common drugs, that is quinine, quinidine, vancomycin. Over here, the mechanism is similar to that of drug-induced hemolytic anemias. That is, antibodies are produced against receptors present on the platelet surface. And once this combination is formed, this complex is then removed from the circulation through the phagocytic cells. These are usually mild and they are reversible once the offending drug is removed. Heparin-induced thrombocytopenia is a severe adverse reaction that can occur to iatrogenic or IV heparin. Heparin, is given in those patients who present with thrombosis. It is of two types. One is type 1, which is the milder form of the disease. It occurs early within first few days of starting heparin therapy, and it is because of a direct platelet aggregating effect of heparin. That is, heparin causes platelet aggregation, but the platelet count seldom drops to low normal, less than low normal. Type 2 is the significant condition which is associated with cross morbidity and the high risk of thrombosis. It usually develops within 5 to 2 weeks of starting heparin therapy. The mechanism is the formation of antibodies which are directed against heparin and platelet factor 4 complex. We know that when heparin is introduced in the body, its mode of action is that it combines with platelet factor 4 and then it complexes with antithrombin and acts on factor 10, or in this way it inhibits thrombin. But what happens is that antibody may be produced against this complex and they then combine to the Fc receptors which are present on the platelet surface. The other drugs, they were combining with the glycoprotein 2B3A receptor on the platelet membrane, but this time this complex is attached to the Fc receptor. And once this complex attaches to the Fc receptor on the platelet surface, the platelets, they undergo activation. There is release of microparticles and procoagulants are released into the circulation. So what happens is that there is, instead of bleeding, because of thrombocytopenia, there is thrombosis, which could result in deep venous thrombosis and pulmonary embolism, which has a very adverse reaction if timely treatment is not provided. And the timely treatment is to stop the drug and to replace it with those other anticoagulants which don't act through this mechanism, which bypass the mechanism through which heparin acts. Now coming to the qualitative platelet disorders. Okay. But before embarking onto it, let me first go through or revise the normal activation or mechanism through which a platelet plug is formed. We know that the endothelium lining of the vessel prevents the direct interaction of the subendothelial tissue with the blood cells, especially platelets. But whenever there is a damage, this subendothelial tissue, which includes von Willebrand factor and collagen, they are exposed to the surface. And now the platelets, they come in contact with von Willebrand factor and they combine with it or agglutinate through receptor glycoprotein 1B59. This first step is called platelet adhesion. Following platelet adhesion, they undergo platelet activation and release phenomena. Release mechanism is by which through different platelet agonists are released, which promote or recruit more platelet to come at this damaged site. One of the major agonists is ATP, and it produces these conformational changes. This is called platelet activation. Followed by platelet activation, other platelets, they come and they attach to the other platelets or they aggregate. This is called platelet aggregation, in which fibrinogen is trapped between two platelets, and the receptor this time involved are glycoprotein 2B3A. So you can say that in platelet adhesion, the platelet receptor involved is glycoprotein 1B and von Willebrand factor. In platelet aggregation, the receptor involved is glycoprotein 2B3A. So there are the certain defective platelet function which can occur if there is deficiency of von Willebrand factor. So platelet adhesion will not occur. Or if there is deficiency of platelet receptor glycoprotein 1B9, again platelet adhesion will be absent. If the release phenomena is lost or there is deficiency of release of contents of the alpha and dense granules, this is called storage pool disease. If the receptor 2B3A is deficient, this disease is called Glenn-Smith's thrombocytopenia, and it will give rise to defective platelet aggregation. So we have got defective adhesion due to von Willebrand disease or due to Bernard-Soulier syndrome, which is the deficiency of glycoprotein 1B, or we can have glycoprotein 2B3A deficiency giving rise to Glenn-Smith's thrombocytopenia. In general, platelet type bleeding is mucocutaneous bleed, whether it is ITP or it is platelet function disorders. Typically, patient presents with mucocutaneous bleed. Okay. These disorders are autosomal recessive, that is why they are relatively rare. That is, both the parents should carry the defective gene, which are transmitted to this child. The platelet count will be either normal or low normal. Bleeding time will be prolonged because it assesses the function of the platelet. And platelet function tests, which are more specific tests, they will be abnormal. Broadly, platelet function disorders are divided into inherited disorders and acquired disorders. Among the inherited diseases are the defects of adhesion, which I mentioned just earlier, including Bernard-Soulier syndrome due to glycoprotein 1B9 deficiency on the platelets, defects of aggregation, and disorders of platelet secretion. The acquired disorders very commonly are due to aspirin and NSAIDs and other antiplatelet agents. These drugs are given especially in those patients who have undergone cabbage surgery or bypass surgery, cardiac bypass surgery, in order to prevent excess clotting tendency. Then uremia. Uremia is a condition, renal disease, in which urea level increases. The exact mechanism is unknown how it causes platelets to become dysfunctional, but it is a common cause of bleeding in renal failure patients. Okay, now, so first we will discuss Bernard-Soulier syndrome. It has got certain typical features. Okay, autosomal recessive, just like Glenn-Smith's thrombocytopenia, very rare, except in our part of the country where, first cousin marriages are common. The major defect is again primary hemostatic defect because it is related to platelets. Prolonged bleeding time with variable thrombocytopenia. This is the condition where platelet count could be low normal, okay? But they are not as low as to cause bleeding. Usually the platelet count ranges between 50,000 to 70,000. The characteristic finding on the morphology is the presence of giant platelets. Normally, the size of platelet is very small, but in Bernard-Soulier syndrome, here you can see that they are almost the size of a red cell. So there are giant platelets on the peripheral smear. The major abnormality is defect in the deficiency or abnormality in the platelet glycoprotein 1b5 now. So how do we diagnose these patients? CBC will show thrombocytopenia with a platelet count between 50 to 70,000. Mean platelet volume, which tells you about the size of a platelet, is high because of the presence of giant platelets, which is confirmed on the morphology. Bleeding time, which assesses the functional activity, is prolonged, and the specific test for platelet aggregation shows defective response to ristocetin. Ristocetin is basically an enzyme which acts to activate the combination of glycoprotein 1b9 receptor and von Willebrand. If this receptor is deficient, then ristocetin will not be able to perform its function, and the platelet aggregation test will show defective response to ristocetin. Then we have got Glanzmann's thrombosthenia. Again, it is an autosomal recessive disorder. Again, it is rare, primary hemostatic defect. It is mostly severe. Its presentation is severe as compared to Bernard-Soulier. The abnormality is in the glycoprotein platelet receptor 2b3a, and these patients have a tendency to develop alloantibodies when they are transfused platelets. In Bernard-Soulier syndrome, how we manage those patients? When they present with bleeding, we transfuse them normal healthy platelets. This is what we do in Glanzmann's thrombosthenia as well, but the risk of development of alloantibodies is high because the transfused platelets, they contain the normal receptors. So this person recognizes this receptor as a foreign body and produces antibody against. So most of the time it is recommended to use a recombinant factor 7, which bypasses the adhesion and directly goes into clot formation. So in Glanzmann's thrombosthenia, how will we diagnose? CBC will show normal platelet counts. Morphology of the platelet will be normal. They will be of normal size. Bleeding time will be prolonged because of defective function, and platelet aggregation test will show defective response to all agonists. In platelet aggregation test, what we do is we take patients with a platelet and we introduce different agonists. So when these agonists are introduced, they cause platelet activation in a normal person. And there is platelet clot formation. In these disorders, the aggregation test will be defective to all agonists except ristocetin, because the other receptor on the platelets, 1b9-5, which is responsible for platelet adhesion with von Willebrand through ristocetin, is wrong. So this result is exactly reverse of what we find in Bernard-Soulier, because in Bernard-Soulier syndrome, there is only defective response to ristocetin. The rest of the agonists